Atkins with the Happy Nipple podcast, coming to you from sunny Connecticut. In thinking about this episode of the podcast, we're going to be talking about trauma. I know that sounds weird when we're talking about birth, but we kind of are. We're kind of talking about how people come through events that don't work well for them or give them some loss of control. And in thinking of the nip tip of the week, I was thinking, that fits perfectly with lots of parents that we see at Oh Baby Lactation. We see lots of parents come to us for validation of what happened before and with hopes of moving through and doing something different with another baby. So I think the nip tip of the week is more of a thought of how to support parents as they move through these events and how can we come back around. And one of the best ways in breastfeeding land, at least, is to explore what happened the first time in a safe environment without parent, and then figure out what that looks like going forward with another baby. And that can be done through a prenatal visit, a private prenatal visit, which is the best thing that you can do in preparation for any birth, is to sit down with an international board certified lactation consultant, somebody with a lot of experience in talking through hopes, desires, physical or emotional challenges that happen the first time, and kind of discover and plan out ways to navigate those and move around through those events that happened before, right? We talk about that. And then ways that we can prepare differently the next time around. What resources do you need? What education do you need? How do we bring in an early, robust milk supply? All of that really matters. So in thinking about support and resources and birth events that don't go the way we plan, I think in thinking about prenatal work is the best way to do that. So reach out in your community, reach out to us here at Oh Baby. We do a great job with prenatal visits, even virtually from anywhere, and plan better, plan supported, plan educated, and you can get to your birth goals and your breastfeeding goals in a much more concise and confident way. That said, let's move on to our great discussion with Melissa Duenas of the Birth Tribe and her discussion about how we support parents in labor and beyond. Hi, everybody. This is Lori Atkins. Welcome to the Happy Nipple podcast. And look where we are, in my office with the lovely Melissa Duenas in person. No masks, Melissa.
I know, it's so great. It's awesome.
It is more than great. It is the best thing ever because it's time to start seeing each other. I hope safely where you are in our space and we're going to be talking about pregnancies maybe that are more challenging, or relationships that are more challenging, and people that are looking for doula assistance in a different way, and how we can work with that and help people get what they need. So welcome, Melissa, to my office. I'm so glad you're here.
I'm glad to be here.
Tell us a little bit about you.
So I'm Melissa Duenas-Witter. I have been a doula for 10 years now. It'll be 10 years this year.
Wow.
I am also a doula trainer for embodied doula training, so I train doulas as well. I run a large doula collaborative, and I'm also a certified lactation counselor and a postpartum doula. I have certification in that. I hold certification in birth story medicine.
Oh, I need to know more about that.
Yeah, we can talk
Tell
about
me about
that.
that.
I hold a lot of different certifications. I don't always use them. I always say, sometimes people enter doula work and their immediate thing is to, learn all of the things, take all of the trainings. I didn't do that when I started. I really just operated as a birth doula only and only took that training for the first few years, and primarily that's really all that I do. Childbirth educator. I do that a lot.
You do? Do you do that with your doula clients? Does that kind of come along with it sometimes?
The childbirth ed.
Mm-hmm.
I think that like when you start in doula work, so much of our role actually is education, and I think there's so many different types of doulas. Like some people are really, really hands-on. Like you had Lisa and Caitlin on, right? Both massage therapists. Like that's sort of their wheelhouse. Me, it is more about education and sort of prepping people for their birth prior. And so I think different styles work for different people. Don't get me wrong, I still help people hands-on. I still help them find and use comfort techniques, but most of my work, because of what I do, and because of who hires me, is usually prior. So, you know, we were talking earlier about how a lot of people that come to me come from a previous history of birth trauma. And that can be from all different things.
Yeah, talk to me a little bit about those words. I think that those two words are getting more traction now.
Yeah.
I'm hearing from my clients about the word, that they're using the word trauma. So I'm really happy to hear that, because that puts my antennas up like, okay, things didn't go well somewhere. Where can I support this family that they need it because they are coming with this experience with them.
Right.
So tell me a little bit about what you're hearing. And
when I started in doula work, most people who were hiring doulas were second-time parents who were coming from a history of birth trauma. So like a decade ago, that was who was looking for a doula, is somebody who had a not great first experience. Regardless of how their babies came out, whether that was via C-section or vaginally, they had some kind of trauma. It's actually what brought me to this work. Like I had my own sort of not great birth.
So they find, I don't mean to stop you, but they come lacking from that experience.
Correct.
And realize, oh, this has got to change.
I need something else.
I need somebody to help me do better and have a better, okay, I got you. Okay.
So that would sort of be, they would come to us, you know, a little bit broken from their first experience and looking for a doula to help. Now we see a shift. Like in the last few years, it's first-time families searching for doulas more often than not, which is nice, you know, because we're sort of helping people to reduce the trauma, right? So they're coming into better scenarios. But don't get me wrong, people still have traumatic experiences even with a doula, like as part of their teams sometimes. You know, it's not all in our control.
Right,
but we reduce it, you know, statistically.
Oh yeah, we were talking about that on our last episode, about those really telling statistics about better birth outcomes.
Yeah, just as how it is, which is great, right?
Right.
And it's nice that people are finding it before they're having a traumatic experience. But a lot of times, you know, what I do is more helping people recover from their trauma so that they are ready for another birth. So a lot of my stuff is sort of mental work about giving them back a sense of control. I think so much of the trauma that people have in birth comes from when they're feeling a lack of control. Yeah. You know, like, I mean, you were an RN for how many years?
Oh, I'm still an RN, but in labor delivery, I was there for 11, 12,
right, a long time,
years,
right?
Yeah.
And when an emergency is happening in a space, everyone starts doing their jobs.
Yes.
Right?
Yes.
So doctors start reacting to whatever they need to do. Usually it's like a baby emergency or a hemorrhage emergency, right? Those are the most common sort of things we see. And nurses start checking monitors and watching for bleeding, and they're running around and they're calling other nurses if they need them, and midwives and OBs are doing whatever they need to do in between the legs, stereotypically, right? That's where they're positioned.
True. Yeah.
And everyone in the room forgets about the brains that are in the space, the mom and the partner,
the hearts and the souls that are in the space
that are happening. And it's not because they're horrific people who don't actually care about their mental health. They want to keep them alive, right?
Yeah.
And as a doula, I don't have to care at all about your baby. I know everyone else in the room has got that part.
Wow. Yeah.
I only have to care about you and how you're going to think about the experience. And so oftentimes my role in a traumatic situation is explaining what's happening.
Yeah.
Like, this is normal. I know everyone's moving fast, but everything is okay. Here's what's happening. Here's why they're doing what they're doing. And it's more of like a whisper, like trying to get them to focus on my voice rather than the chaos that's happening in this space.
It's a guide.
Yeah. And so a lot of times in those scenarios, afterwards, you know, when people leave reviews, it's like, all I remember is hearing Melissa's voice in this place, right? And I think a lot of doulas operate that way.
Yeah.
So when people come to me who maybe have had a previous traumatic experience, a lot of times it is just working through giving them back a sense of control. And one of the ways that I do that is to create multiple birth plans. So like sometimes people poo-poo on birth plans, but when an emergency starts, I can say, remember we talked about this, and this is what you decided if this was to happen again. And so it gives them a semblance of control, right?
Right.
Also, having that education, working through that childbirth ed, also means that if I've talked to them about all of the things, I can remind them, we talked about this. Remember when I talked about how this thing could happen during your birth? It's happening now, but we made a plan for it. So like, I don't like the term birth plan necessarily. I call it birth preferences. Like
Birth preferences?
Yeah.
Just that little switch in the word is
because
interesting
it's a
to me.
reality. We don't really, again, don't have control.
Plan, right. Preferences, birth preferences. And I think birth plan, the term has kind of gotten a little made fun of.
Yeah, and I think that's
years.
I think
and
that's
as a nurse for a
medical
long
thing.
time. Oh
Right.
yeah, the nurse that we used to. I mean, when I first heard the term birth plan, I was working in labor and delivery, and we would do the little eye roll.
Yeah.
Birth plan. She's got a birth plan. Oh, you know that's going to be a disaster. I hate to tell you, but that's what people used to say.
Right, and I think that that's really common. And of
It's
course,
terrible.
as a
No,
doula,
I think
we
back
know
now,
that
and I
like
think it's terrible.
right that's they're so beneficial, and really they're just ways to educate people on what their options are.
Yes, and educate. I say to people, you've never done this before.
Right.
Why wouldn't you plan, or at least hear the terminology?
Right.
So many things. So much childbirth education has gone bye because of the pandemic.
Right.
I ask my clients all the time, did you have some childbirth education? Oh, well, we saw some YouTube videos, ...
I mean,
and then nothing. And I'm like, oh, wow, how is this falling apart and falling away? And I think that we're going to kind of pay the price for that.
yeah, I think too, as doulas, like a lot of times people think if you have a doula, you don't need childbirth ed, but you really do.
Oh,
like
course
you need
do.
it all around. So, like for me, when a client comes on, I just offer everybody childbirth ed as part of their package because I want them to take it. Like it's much easier for me.
Yeah.
If you and your partner know something about what's going to happen when we get in that space.
Yeah,
right?
Or what they want, or what they can do, or what the choices are.
Right. And so I create that birth preference, like this is their ideal birth. And then I create a preference for what happens when things go wrong. And then I create a preference sheet for like what happens in a total emergency. Like what happens if you've had a C-section before and maybe you're trying for a VBAC, which is a lot of my clientele, vaginal birth after cesarean section.
I was going to ask you a little bit, we're going to talk more about that.
You know, let's create a plan for a C-section if you have a repeat and make it a much better experience than you had the first time. What happened in the first one that you hated? How can we combat that? And sometimes it's really simple, like it felt more traumatic because I was throwing up the whole time, right? That's a really common thing that people don't realize.
Or
that people
shaking,
vomit.
shivering because of being
well,
cold.
we can just give you
fentanyl.
Zofran. We know that you vomited the last time. Let's just get Zofran on board before we even go in there and stop that thing.
Let's
like,
talk to the doctor and include
it
them.
can be so simple, making little adjustments for people to making them have better experiences. And obviously, like, it depends on where you go. You know, choosing a provider is really important, and choosing a place of birth is really important when you're looking for something different than you've had than your last birth.
And we operate in such a local kind of thought process because that's what we do. But if people are listening to this that live in places where they don't have a lot of choices, I think it's going to be more important to for them to kind of operate within their space. Like, what can they do? So maybe they don't have a choice of hospitals. Maybe they don't have a choice of providers so much. But then within what they have, you know, how to find those people that can support them.
I mean, I think the best thing that anyone could do, obviously, as a doula, is to find a doula because they've usually done all of the research, especially someone who's been in the industry for a while. If you can't afford a doula, like, let's be honest, that's sometimes the reality of this.
Yeah, that's true.
Is a doula most doulas who have been around for a while will give you the opportunity to talk to them about provider choice. So, like, I offer provider consults. So there are people who schedule a meeting with me and we hop on Zoom and I go through all of what their needs and wants may be. And then I point them in the right direction of these are the 3 providers I recommend. Do interviews with them.
Wow.
And see who connects.
I didn't know you did that. That's really cool.
Yeah. I mean, I think it's so beneficial and can really impact you in such a significant way. And I want to make, like, the data shouldn't be, like, gate-kept, you know, but, like, I think it's hard to find statistics about providers.
True.
And sometimes, you know, it was significantly much easier prior to the pandemic. And now, like, I used to be, like, the one that could find them. And now I even struggle to sort of find those numbers. But we know, because we work with the providers, right, of how things may feel or what may be the right fit. Because it's not one fits all. Like, you know, I'm sure you're in tons of, like, mom groups on Facebook too, where like people are like, oh, you should see this particular practice, and everyone's like, I second this practice, I third this practice, I fourth this practice, and I'm like, hold on, all they've said is they have this due date.
Right,
you know what I mean?
right.
Like,
They don't. You don't know anything else about them.
No.
Right, and let's talk about our clients that come from different kinds of family structures.
Right.
Yeah, we have people who could be really damaged by working with some providers who are not supportive of alternative.
Sure.
Lack of.
I mean, you
a
and
better
I.
Term.
Yeah, you and I have lots of clients that fall in all different categories,
Absolutely.
right? So you and I share a lot of LGBTQ plus clients.
Absolutely, we do.
Trans clients, secondary, lesbian couples where one parent is birthing the baby, but the other one would also like to lactate. Like, we have all of these different things that come to us. And then people even like, a lot of my clients, I'm in this field, sometimes you end up serving subsects of communities that just like fall into your lap. A lot of my clients are Orthodox Jewish women.
Wow.
And so you end up in these spaces without realizing that you were going to end up in these spaces, and then finding the people that fit. Well, they don't always work for different cultures, religious backgrounds. Like, one practice doesn't fit everyone just because they have good stats or good rapport or because we like them.
Right. That's very true.
And so if you can find somebody in your area that does have sort of knowledge of all of the providers and have worked with people, they may be able to steer you into the right one for somebody who fits best for you. Even like midwifery care. I mean, I think last year was called like the year of the midwife was something that I heard, and midwifery care is like increasing, which is how it should be.
It should be.
But not everybody can use a midwife. If you have a significant heart condition, if you have, there's so many things that can pull up where you need an OB overseeing you. So then let's look for a split practice, right? That's half midwives and half OBs, so you can still have this type of care that you're looking for, but while being watched by an OB at the same time.
Right. Or that care. What I like about split practices like that is that can switch kind of seamlessly. Like if you have midwifery care and they need to rely more on the physicians for either delivery assistance, or it's going to be cesarean, you have twins or triplets, or you have a bicornuate uterus, or some kind of you're coming into the pregnancy with a lot more challenges than maybe your friends or people that you know, and you feel like, how can I do this in a way that still supports my birth preferences, because I'm going to use your term.
Yeah.
That it's nice to be able to have that back and flow, and it's in the same practice. They know you. They've talked about you in a good way.
Right.
They've kind of anticipated challenges in your care, but still can have that midwifery model of more hands-on care, longer time, more of a quiet support.
Sure.
That I think people are looking for.
Like, exactly what you mentioned. I have this client. Her name is Victoria. She's awesome. I've talked about her birth a bunch. She's open with me discussing it. But she was planning a home birth and found out she was pregnant with twins. Oh. So in our state, none of the providers that were open to her would deliver twins at home.
So no home birth, no twins.
No, there's one practice that will, if you've already had like a vaginal birth and that kind of thing, but they don't take insurance, right? So then it becomes an out-of-pocket cost, and for her that wasn't an option.
Right. There's not a lot of families who can support that.
No, right? There's some are. I mean, when we look at our high deductible plans and the way that insurance is now, it pretty much costs you the same. So really take a look.
That's a good point.
It's sort of ridiculous, but anyway, she had good insurance, but just so then she needed to have a hospital birth essentially. Well, she then found out that they were sharing a placenta, right? So they were mono-di twins, which then makes her situation a little more complicated.
Right. There's more challenges with that pregnancy because there can be. They have to be monitored really closely.
Right. So that was the piece, is that she requires more monitoring, right? So she was devastated when the home birth practice was like, you're going to have to find a doctor. And then when she went to the practice that was recommended, they said, no, like, you're a C-section, or you're an induction at 37 weeks, I think is what they were offering her. So one or the other.
So those babies were coming.
Yeah. And so someone said, another sort of weird subsect that I've fallen into is twins. So lots of twin births. And so someone recommended her to me, and I basically begged a local provider, Manchester OBGYN, to take her. And she's outside of their service area. And so they originally told her no. Okay. And so I wrote a letter, basically like begging. And one of the doctors, Dr. Gunn, offered to sort of meet with me and discuss it with me. after I sort of pleaded her case, I was like, they're just offering this person who's already had a vaginal birth, right? So like proven pelvis, which I sort of hate the term, but it's the reality
so
of
they've
some
had a
of
baby
this stuff,
before,
right?
so it's better chance of a vaginal delivery.
Right.
Okay, gotcha.
And she didn't want to be induced. She wanted her babies to be able to come on their own. And if they were going to be an induction, she wanted it much farther than 36 or 37 weeks.
Right.
And she was willing to do all of the monitoring. And so luckily we sort of got her on board, and then she got everyone else in the practice on board.
Wow.
And it felt like such a win, right? Like we were doing something unique. Like we had gotten a practice to support her. And she had to go like 3 times a week for NSTs where they like monitored the babies. And of course trying to monitor 2 babies is a real pain in the bum.
Right.
And she ended up going full term, like to 40 weeks.
Really?
And they brought her in. She only had like one sort of little intervention, and her body kicked in on her own, and she had an unmedicated vaginal birth of monodi twins, and it was like,
oh my goodness.
and that was a split practice, right? So midwives and OBGYNs, and the midwives cared for her the whole time with like very limited interaction from the OBs, only when they needed. The only time an OB ever walked into the room for that birth was to make sure that baby B was head down with an ultrasound.
Wow.
And then when it was, he stepped back, and a midwife caught both of those babies as well. So that was like something new for that midwife who had never had that experience either. And she had been a midwife for like 15 years or something.
Wow.
And I thought, like, this is the thing. Like, these are the providers we're looking for. Is when it makes sense.
You know what though? The word was like flashing in neon in my head when you were talking just now. Advocacy.
Yeah, that was all it was. And I think it was.
I don't think it's all it was. That's a huge thing.
No, I think
don't minimize that because that's a big deal.
It is.
It really is. It's a big deal. People don't ever feel advocated for anymore, I think, and when they do, it's such a weird feeling. Like you don't expect people to go to bat for you anymore.
Yeah.
Like I don't know. When you do, it's almost uncomfortable. So that's a huge thing that you did.
I think it was the first. Sometimes doula training in the beginning sort of told us like we're supposed to teach our clients to advocate for themselves. Like that's was like a big term.
Okay, yeah.
But it's like not real.
Yeah.
People who are in labor land especially, like how is someone who's contracting every 2 minutes going to advocate for themselves? They're not, especially during birth. Right. And so for me, like that just never felt like the right thing to do, which sometimes like had me looking a little bit like a rogue doula when I was like trying to, get things to shift.
Did you like wear a mask and smoke a long cigarette? It looked really cool.
I think that was the first time that I was like, oh, this is actually something that we can get people to do things if they make sense, and we can make a good case for it. Like I looked up all the stats and like pulled studies and trying to like get people to sort of agree. And I think if you can come at it with data and not just like, please, because you like me, really. Right. The information, it was helpful, and I think that was all it takes is to get one person sometimes on your side, and then sometimes other people will follow.
That's a big deal. So tell me a little bit more about what you do with VBACs, and how are people finding you, and what do they want different? Like tell me a little bit about that.
Sure.
I know you do a lot of VBAC work. VBAC for our audience is vaginal birth after cesarean. Just to clarify. Go ahead.
So, usually after somebody has a birth that they didn't like the outcome of, which a lot of times is a cesarean if you were planning a vaginal birth. It's just sort of how it is. People will find me usually on Instagram or some type of social media. And sometimes it's like days after they've had a baby.
That's amazing to me. So they've had one baby and had an experience that they didn't love, and they're reaching out for support for the second baby or third or fourth, whatever.
A lot of times before they're pregnant.
Wow.
That is always like hard. I'm like, let's like wait and unpack what you have going on, first. But a lot of times it is about finding them the right therapist. Right?
Which we're going to definitely get into on the Happy Nipple podcast.
Yeah, I mean, so there's that
coming
piece.
soon. Yep.
And then there's the part where talking about the provider they had. And sometimes people will say, I should have switched providers, but I've been seeing that provider for many years, right?
As a teenager.
Yeah, or my mom saw that person. Right. Like, that's the most common thing I hear is like, oh, this is where I went because my mom went there. Which makes sense, right? Like, of course,
it makes sense, but that person may not be the right person.
No, and I think we choose providers in the wrong way. So a lot of times, a lot of us pick a provider because they're close to us, right? Because they like down the
Or
street.
they're in your insurance plan. Let's
Right.
be honest. Sometimes it's a practical matter.
And really what we should do is look at our birthing locations.
Mm-hmm.
What do they offer that we might want as part of our births?
So as a consumer,
Yeah.
yeah,
And then drill down into the providers that
that operate under that umbrella of that institution.
Right.
Oh, I get what you're saying. So find out a place where you want to have the baby first, and then
Right.
kind of go down that umbrella.
Right.
Mhm.
So, like a lot of times we go the opposite way. And I've had clients who are like,
Right.
oh, I'm seeing this practice. They don't deliver at this hospital. And you're like, no, practices are only associated at one hospital. And a lot of times people don't know that.
That's a really good point. Say that again.
So each provider really only catches babies at one hospital, usually.
Right.
And people don't realize that.
Right.
They think like, oh, I can still see my practice and have a baby at this location. No. Like they're
Yeah.
only insured and liability and all
Right.
of these
They have
other
to be
businessy
credentialed within
things.
one or maybe two institutions. Connecticut,
Tops.
there are a couple tops. That's tops.
Taps.
So if you have a place that you want to deliver because you've heard good things about it, or they have water facilities, or they have a birthing center that maybe has some hands off, you have to start with the facility first.
Correct.
I'm sorry, I'm just killing this point because it's so important.
It's
for
so
people to
important, and I think it's I don't think a lot of people
Mm.
think about it that way until I like mention it. Like we really should start. What do you want as part of your birth? Water birth is a thing that just isn't offered in a lot of places at all.
Absolutely.
I mean, and in Connecticut where we are in a more progressive state, and there's still only two places that you can do that, which
Yeah.
is Danbury Birth Center and Manchester, or Manchester Memorial, but it's ECHN now, right?
Right.
So those are the only two places. Nowhere else will hospital policy allow for you to have a baby in the water. So if you're looking for that, then you've got to start with those two places. And then Danbury only has one practice that does it, right? The folks that are the midwives at the birth center.
Mm-hmm.
And then Manchester has a few that will, and so then you can look at those. But you really have to start there. And so when people are asking me, when they come to me after having had a cesarean and are looking for a vaginal birth, I say, well, let's look at the two places or three places that have the best VBAC stats,
Right.
where you can get what you want. And sometimes that switching a provider is the hardest thing for people.
Mm-hmm.
And I tell people, like, if this is what you want, I'm not going to go with you to the provider that you have, that you've just had, when you want to have
had
a
this
VBAC.
terrible experience, but you're
Yeah.
still going to go back to them anyway.
Right.
Yeah.
Sometimes it makes sense, right?
Right.
Sometimes people have cesareans that are needed.
Oh,
and it has
gosh.
absolutely nothing to do with the practice.
Right.
And they're with a great practice.
Right. It's just their own experience wasn't what they needed.
Correct. And
Right.
so sometimes people will
Oh
stay.
yeah, we don't want to bash providers here.
No,
I
not
know.
at all.
Trust me, I know all the time things don't happen, or things happen out of a family's control.
Right.
But it still can be, if it's supported and guided correctly, it still can be a positive experience. But if it's not,
Right.
and sometimes the provider wants to.
Right.
Like you said before, you made a great illusion of this, everybody doing their job, especially in an emergency.
Yeah.
And then not focusing maybe on that guidance that the family needed.
Right.
Even if this has to happen, at least I can guide you that way.
Right.
And I think sometimes that gets lost in sight, or the provider thinks they did a great job in guiding this couple, but the couple or the family didn't really feel that way. So maybe that's where that disconnect occurs. So I don't want to bash all those providers out
No,
here.
because there's
we
so many
need
great ones.
right, we need cesarean births.
Absolutely, they should exist.
And there are plenty, right? There's a reason for that. I used to call it the northern route and the southern route. You know, we want babies to come out that southern route, but sometimes they need to go north and
Right.
have a cesarean, and it
Right.
saves mom and baby.
Right. And we know statistically that cesareans happen too often. Like we
Oh,
all
they
know
do,
that.
right? But
There are providers who are combating that. And so we should really look at that. Like who has the lowest primary cesarean
Right,
rate? So
that's
like
a
your
big
first cesarean. Looking at that and then looking at who has the best VBAC rates. And sometimes that means that the place that has a tub for you to labor in isn't necessarily the best or closest place to you. And there is a place where you have to give up wanting water in order to get your stat, in order to
right.
get
So
maybe what you
sometimes it's
desire.
just making choices that work within the confines of what you want.
Right.
It's like anything else in life. You're never going to get the perfect scenario, but
No, but we
maybe
can
we
make
can
better choices.
right, you can find what really works for you.
Yeah.
Right.
And I think that's usually my first route is, are you willing to switch providers into a birth location that's going to support what you desire? If people say no, then I'm probably not your doula, because I'm not going to sign on for something and think that I can help you achieve, having a vaginal birth after cesarean with a provider that isn't going to let us get there. And there's things like...
And then it's, again, you're setting them up for more trauma because they thought they were going to get this again, and it didn't turn out that way.
Right.
Right.
And so there's a really big difference between, like, tolerant and supportive providers. Those are two different words. Like, there's plenty of providers who are like, yeah, we'll let you try for a VBAC. Like, but you have to...
But
you have to have the baby by 39 weeks.
Right.
You know, you can't have gestational diabetes. You can't have any preeclamptic stuff come up. You can't be over 35. You have to be 3 years out from having had a cesarean. Like, sometimes they have these rules. Having a baby by 39 weeks is often a common rule for tolerant providers. That's just not reality. Like, babies don't come at 39 weeks. You know, most babies come after that. Like, statistically, we just know that. And so then there's a supportive provider who's like, yeah, let's get you a VBAC. Like, I want you to have a VBAC. Not, let's try, right? But I want for you what you would like.
Right.
And I'm willing to let you, you know, I'm willing to let you choose your own path. As long as they're within the confines of the things, like providers who, obviously,
they still have to, you know,
and there's still
terms of
hospital
safety.
Policy, like
there's hospital policy, which may be different from what the provider wants to do.
But someone that will, you know, support you going past your due date, because we know that that's more stereotypical.
Right.
Someone who doesn't feel like you need an epidural placed just in case, right? Some providers will also say that.
Just in case you have to run down the hall for a C-section.
Which is silly, right? That means they're not actually thinking that you're going to do this, right?
Right.
People who, our locations here, hospital locations won't let you birth a baby in the water if you're a VBAC, but they will let you labor in it. So you can ask that, like, can I labor for as long as I want to in these other places? That's a big one. You know, there's certain things that you can ask, and it can really guide you. Like, okay, this person is saying they'll let me have it. Like, they'll let me try. But this person's saying, yeah, let's get it for you. That's such a different vibe.
Right.
And, like, I think what you said before, too, like, we are consumers, and we don't always think about that in healthcare.
No.
We think that...
You think you get what you get.
Yeah, and it's just not
sometimes
the case.
Sometimes it's true.
It really is a service industry.
So what I have to say, when we did, pre-pandemic, when we did tours at the hospital that I worked at in Hartford, we would do, you know, birthing tour, and we were amazed in the last few years to find people that weren't even pregnant that were going on the tour. And I always wondered why, until I had conversations like this, and then I realized people were shopping.
Yeah.
And then I think even the hospital started to get the message like, oh, people are choosing where they want to be. And it's not this old dinosaur thought of us. You get what you get. You get what's in your neighborhood. And
I mean,
be
especially
happy.
in Connecticut, there's like 20 or 30 something places that you can have a baby, right?
You've got choices.
And you can get to like 3 or 4 of them within like 30 minutes.
Right. It's a small state, so
when
we're lucky.
people are like, oh, but I have to drive by a hospital to get to this other one. Well, you should drive by it. You know, there's some things you should drive by.
No, it's easy.
And so, you know, that can be the hurdle, the first sort of hurdle. And then it's talking really about sort of trusting their bodies. I think so many people that have negative outcomes sometimes lose, you know, went into it like really believing their birth was this magical thing, and now their body has failed them somehow.
Oh, yeah.
And a lot of times that's where I'm like, okay, we need to talk to a therapist. Like, let's get you reconnected. And sometimes there's other ways to make connection, you know. Like, I do a little bit of energy work, Reiki and things like that, but that birth story medicine, which is about, it's a Pam England created it. And it's a process in which you basically process your birth in order to sort of take a next step and heal for the next one. And sometimes a lot of people
That's
need
awesome.
that. As much work as we do, though, I will tell you, like, most of the people that come to me having previously had a traumatic experience, it comes up during their birth. Even if
it comes up in the second.
Oh,
yeah. You see the same kind of, or hear the same things, or get the same feelings, yeah.
Especially if it ended in a cesarean or an emergency. Like, failure to progress is a really common sort of thing where people only make it to a certain centimeter dilated and then, like, the body stops. I have a lot of feelings about that. I think it's, like, failure to be patient by providers. But a lot of times they'll get emotionally stuck at whatever centimeter dilated they were the last time.
Right.
And so I have clients who will have C-sections at 5 centimeters, and then their next birth, they are in the same exact place, 5 centimeters, and we get sort of stuck at 5 centimeters for this extended period of time. And then we have to talk through it, and then there's like a breakdown and crying and sobbing and sort of like giving over. And then a lot of times we see dilation start and like the shift change.
To get past it.
Yeah, we're animals, right? I mean, we are primal in birth, even though we don't want to think that we
I
are.
think that is such an important thing to talk about, because we're also primal in breastfeeding, and I don't think people know that. They think we're cool. I say this all the time. We think we're cool because we have iPhones. We're cool because we're human.
Yeah.
And we hold on to those traits, those cave person traits that never have left us. Why do you think babies have reflexes? What infant reflexes are is they're to protect them as they move through being tiny, defenseless humans trying not to get eaten by saber-toothed tigers in the cave. People look at me slack-jawed when we talk about that. So it makes total sense to me that we also have muscle memory.
For sure.
So that cervix is remembering what your brain is remembering, what your heart is remembering, what your soul is remembering.
And if you're telling your body, your brain is saying, we're not safe.
Right.
Your body's going to stop.
Mm-hmm.
Right?
When you move an animal who's in labor, what do they
stop.
Right.
And I think that that's such a thing, is sometimes it just has to be like a release into the fact that you are capable mentally and physically of doing this, and then things will start to move along. Sometimes people aren't, it's hard to let go, right? Especially if you previously had trauma, like you're just putting yourself back into the place where you experienced the trauma the first time.
Right.
That's sometimes why I tell clients, like, there's got to be, sometimes an epidural can help you. Because if you get an epidural and you fall asleep, and your mind is out of the way, a lot of times we see a cervix open, right? I mean, that's a really standard thing. And so sometimes an epidural can be our best friend in those scenarios.
What I'm thinking of, again, listening to you talk and talking about guiding, I think when people think about doula care, they think everything is crunchy granola and it has to be biting a rope in the woods and squatting next to the stream for the water goddess to catch your baby. But that's not what it is.
No, and I think that's such a common thing, especially in like, my clients, like mothers, like grandmothers, think I'm like gonna come in and like sage the whole house. And don't get me wrong, like I'm indigenous, like a lot of my own personal background definitely does come from like a very holistic piece.
Yes, no, I
and
love
there
that
are
part.
some doulas that are like that, but a lot of us aren't like that. And we are educated and can speak on lots of like high level medical topics, even though we're not medical professionals.
Yeah.
But we're not all like that. And a lot of times like in movies and things, we're sort of portrayed like we're outside, with our clients having a baby next to a fawn, and that's just not.
I'm sorry, I don't mean to laugh at anybody with their baby next to a deer.
But it's true.
No,
right?
No, that's what I'm talking about. Is as you were talking about guiding, and I think Lisa D'Souza used the term Sherpa the last time that we talked about this, and I love that, the Sherpa through the birth guide. And I'm like, that makes sense to me, rather than just what you think a doula does, and that's why this work fascinates me so much, because I see such excellent outcomes, and I hear, like I've said before, I mean, I've seen, when I get clients from doulas, I always feel that they're being carried to me by a set of hands.
And that's really what it is.
They feel that. They feel that advocacy and those we talked about referral networks, how important those are. And I feel that for them, and I think it makes a difference, but it's not all chanting and chakras.
No, and like I teach calm birth too, like I teach meditation and things like that because it's helpful, but it's really about sort of learning how to clear your mind out of the way in case you're in this place, right?
Yeah.
So, but there's so many doulas that don't just support people only having like unmedicated vaginal births, which is what I think is sort of a thing that a lot of people think is like everyone who hires a doula is trying to avoid an epidural. That's not always the case. And we have doulas that specialize in cesarean birth.
Yeah.
People who hire doulas and they're planning a cesarean. They have a planned cesarean for whatever reason. So doulas can sort of support you through any of the things because there's still education and choices to be made and things that you have to know and help reduce your trauma surrounding any type of birth that you may choose.
I want to circle back and talk about our LGBTQ plus community and how challenging it can be for them to find providers that can be supportive and helpful. I know how we work together, but tell kind of a little bit more about how you're finding things for these families.
I think we do live in a progressive part of the country, and so I think that's so important to mention for other people who may be listening from other places.
That's a good point. Here,
it's not as hard to find supportive providers, but there's still stigma in everything, right? Like it's stupid to think that we have no bias, right? When people are like, "Oh, we live in Connecticut. There's nothing wrong here." There's still like so much wrong here. We still have high rates of, Black maternal death rates are significantly high, and all of these things still exist here.
We have so much work to do.
However, there are places where you can find like really lovely support, and a lot of times in places you don't expect it, which may sound odd. So, midwifery care is so woman focused that sometimes people who don't identify as women feel really ostracized.
That's interesting, really.
Yeah, I mean, think about it. If you are identifying, if you're a man with a uterus, do you want to go see a practice that has the name women in it? Maybe not.
Wow.
And so seeing a practice that is just like blank OBGYN or blank physician or whatever maybe feels like a better fit than an all midwifery practice that's like, you know, whatever.
Interesting. So it really is finding who you think is going to work for you. And
Sure.
how do you do that? Like,
I mean, sometimes
how do your trans clients kind of navigate that?
I think
maybe
that's
an
the
issue.
hardest
Yeah.
piece. So, and even like, you know, I have plenty of clients whose partners are trans. And so, identifying who isn't going to put them like in a weird place or box or use proper pronouns or that kind of thing, you know, I think, unfortunately, in birth, like being misgendered is just part of the deal, unfortunately.
Oh, do you know, we fight about that in lactation land. I cannot believe, I mean, for most of the time, my lactation peers are amazingly thoughtful and want to learn.
But not
Even
all of
I
them.
struggle with, they, using the pronoun they. It's plural to me, but I want to support you where you are, and I'm going to freaking try.
Right.
I'm going to try.
And listen, people are going to make mistakes.
Right.
And I think it's just about owning it. But, like, I will tell you, one of the most supportive providers for trans clients is a 65-year-old white male.
Really?
Like, cishet male, like, he is never messes it up. I don't know, I mean, that's how it should be. Like, he's ideal, but people are always surprised when I recommend him, and then they're like, oh, this was the right fit for me. I don't know why. Because there is something in him that, I don't know what it is. I don't know if
He wants to meet you where you are rather than bring all his baggage with him.
Correct, he just doesn't care.
And like I said, there was just kind of this online kerfuffle recently in lactation land. I say that in, like you said, birth land or labor land, where there was the lots of providers. There was a study that came out that we were shocked about using misgendering, pronouns, and basically how dangerous using alternative pronouns is to other. Like, what? How is that dangerous to someone? You're going to take your womanhood away because I'm going to give you the choice to tell me if you want to identify. That it made no sense.
Yeah.
So there's a lot of learning to be done, but I think it's important that we tell people out there who don't use those pronouns or wish someone else didn't. Maybe it's okay that most of us are trying, and we will work with you.
Yeah, and it's interesting too, like when people are like, oh, it's a plural pronoun. I'm always like, well, when we say, I mean, and I think that's huge. Like, it's just to be aware.
Yeah, yeah.
Is if you said to me like, oh, my coworker got into a car accident, I'd say, oh, are they okay? That would be my response.
Right.
Even though I'm talking about a singular person, because you never said she or he got into a car accident. Right? You'd say my coworker got into a car accident. Oh, are they okay?
Right.
So we all use it as singular all the time.
We just have to think about it.
It's just when we're doing it that it feels, for some people like an oddity. And it's
not. It's just a matter of getting used to something else for someone else's purpose.
Mm-hmm.
It's not about me. It's about how my client feels comfortable. Right. And we should be focused on that.
Right.
I'm sorry, I'm off on a rant, but
it's okay.
It's important to talk about that. But as far as these families getting care, in Connecticut, like you said, I think we're better. I'm finding more clients feeling really supported through the process, but I know that there are places that that's not so true.
Yeah,
Do you have any suggestions for people how to find that care that works for them?
There's a really great there's many great Facebook groups, and I think those are really the place to start is in your own community and find out where people are having success. And that's look to your own community. Sometimes you may feel really isolated where you are, but stereotypically there are like plenty of folks who have done this before you, like most of the time you're not paving the first initial path. And so find someone that's done it before and start asking questions. And I think most people are really open to sort of telling their stories. So yeah, I mean, trans births is like a whole other thing. And I think it is sort of like, I mean, a decade ago, like if you were, a lesbian or gay or queer or using a surrogate as a gay male couple, like it was sort of like a big deal. We've now phased out of that, right? I think we forget that like 20 years ago, people that fit in these categories didn't have rights, right?
Right.
Because we're so used to now that it's adapted. And now we're just moving into the same thing in the birth field with trans folks. And so we're watching things change and things are progressing forward, but I think a lot of times like New England sort of is the first to sort of be accepting sometimes.
Yeah,
or like
I can totally
whatever,
agree with that,
people
and
are.
I'm sure that it's important for me too, even
In the U.S., let me just
put
say
it.
that.
Yeah, be
You know,
clear
lots
about
of
that.
other
You're not
countries
right. There are
significantly
places that
further
are
ahead of us.
way ahead of us
Uh-huh.
in the curve,
Uh-huh.
but right, this part of the country, and I find that if you get that out of the way with a family about I'm good for you and I'm going to support you no matter what, and your lifestyle is your love is love, and
Right.
let's just move on and actually talk about the breastfeeding.
Right, like
what
we don't actually. I
we
don't
don't-
care who your partner is or
we
any of that
just
stuff.
move
Right.
on, and
Right.
there could be different challenges, like you said when we were talking about inducing lactation with a non-birthing parent. Okay, let's do that.
Right.
You know, we don't even. It's just. I just want that family to feel supported no
Right.
matter how they're coming here
Right.
for care, or you to anywhere for care.
When someone comes to you, like a lesbian couple, or you know, a couple that has 4 boobs, as we were
We
saying
talked about
earlier,
that.
right?
4
They have
boobs
4
instead of
boobs
2.
instead of 2.
Yeah.
How does that work for you? Like as far as you know, the process of inducing lactation. Like
It
what are
is
your
all about we spend a lot of time talking. And again, you're talking about what your needs are and what you want. Did you just read about this and think it's kind of cool, or did you have do you have a medical reason why, or is there some kind of focus on the birthing parent that there could be like the breasts are really not something that that makes them feel
right that they
misgendered.
Right.
So there's such a discussion about what that family needs. And so the physical part of induction of lactation, there's lots of ways to do it. And we can certainly talk about that another time and more extended, but we spend a lot of time just talking. And so I think sometimes I've had clients that have changed their minds about induction of lactation because they thought, like I said, they thought it was something that was kind of cool for them to do. But once the reality of what that means is, okay, so there's 4 boobs instead of 2, which we laugh about. But that means there's 4 breasts that need stimulation. So, and there's only 1 baby. So there's a lot of pumping going on. Do we really want to do all that pumping? I don't know if I want to do all that pumping. There are maybe things that I don't want to think that I didn't think about.
Right.
So we talk about that.
Yeah.
And so, and it can happen anytime. You know, usually it's nice to get a 6-week lead because the breasts need to kind of know what to do without stimulation. But so there's a lot of talking, and I think people are surprised by that. They think, how can that happen? How can that magically occur?
Yeah.
But it is more of a process of families finding what the reality of that will be.
Yeah, I guess I hadn't thought about that. It takes a lot to breastfeed,
It
right?
does, and if you have 2 breasts that have not had a baby,
Yeah.
sorry, that sounds weird.
No.
That we need, the stimulation is what continues milk to be produced, and so there's a shit ton of pumping.
Yeah.
And so sometimes that doesn't work for a family who's got a newborn,
Right.
and maybe that other partner's like, I don't know if I have the time, but I'm going to be doing the grocery shopping, and I'm
Right.
getting up with the baby in the middle of the night, I'm doing all this stuff, and I have to breastfeed too. But then there are other families who, I worked with an adoptive mom who had 3 children, and she was adopting a 4th. And she had had a breastfeeding experience with her last child in the last few years. So she put on a wearable pump, and she wore it all day long. I swear to God. She changed the batteries out. That was it. She goes, I'm too busy for this shit. She goes, I got 3 kids, and I'm running around, and I'm just going to bring in a milk supply this way. And do you know it worked for her?
Yeah.
So that worked for her.
It's probably easier to relactate though, right? Like once you've already lactated.
Yeah, I say yeah, but still, it's kind of, it's stimulation, and sometimes it involves hormones. It depends on, it really is such an individual assessment about using a birth control pill or using domperidone, which is a medication you can't get outside the stage without lots of agita. So anyway, it really is an individual assessment for each family that comes to talk about it. And then sometimes I leave them with more questions, like I said, than they originally had. So they have to kind of think about what they're really willing to do. But it's one of my favorite things to do because I love kind of going on a journey with a family to figure out what's best. And sometimes what they thought it came in with what they wanted isn't what they ended up doing.
Yeah.
But it's so fun because I just want them to feel like whatever that is that birth experience, is that nursing experience something you want, that you really want? Yeah. Okay, we can do that in other ways. There are parents who use devices to just feed at the breast, and they don't need their own milk. Maybe they use their partner's milk.
Right.
I have a couple right now who's to start to do that, who's going to start. Non-birthing partner is thinking about nursing baby with a device, a nipple shield, and a little syringe at the breast, just to get that experience and that closeness. That doesn't necessarily have to be her milk.
Right.
Does that make sense?
It totally makes sense. I
Yeah,
think it's
so
something
it's
too,
really, it's so wide open. So that's why it's kind of like, okay, we'll start here with this pathway, and then we're going to wander down the individual making decisions.
Yeah. I think sometimes too, like, especially in American culture, I mean lots of other cultures, but we think like feeding people is how we show love.
Right.
Right?
Yes, absolutely.
And so when you're a non-birthing parent, sometimes you're like, well, I need them to pump and give me a bottle, because how will I make a connection with this baby if I don't give it food?
Mm-hmm.
And sometimes that's such a huge topic too that I have with clients. Well, like, there's so many other ways to make connections with children rather than like giving them food.
Right. And I think grandparents too, they think that's the only way. We get these overfed babies sometimes, and because grandparents just want to feed them. They don't know what else to do. And it's such a, you're right, food is so central to our parenting.
Right, but there's so many other things. Like my children's father, you know, well, I had a baby that wouldn't take a bottle, which is a whole other thing. I'm sure you could have undone that, but
I don't know.
But he wouldn't. And so, you know, their father baby wore them all the time, skin to skin, around the house, vacuuming, when he cooked. Like, I would nurse them and sort of like just pass them off to a baby carrier so that when I wasn't there, he had a way to get them to sleep, right? Like, he had other ways to do connection with them and for them to be comforted by him. And for him, it just fell into like a baby carrier. He wore them for years till they were like 4 or 5. They would want to go up.
That's awesome.
With him, because it was their
but
thing.
But it worked.
Yeah.
I think every family has to find those things that work, and sometimes you don't know until you do them.
Correct.
You can prepare all you think you can prepare for, and then at the end, it's just whatever it does the thing.
Right.
Is it the bouncing ball? Is it the shushing? Is it the shusher? No, that shusher machine.
Rocking.
A million.
All those
walking
things.
around outside.
And then you know, and then I'm sure you get the things too, like, oh, we're creating this bad habit for a baby, and I'm always like, oh, there's no bad habits. Like, your baby isn't going to be 17 and need to be rocked to sleep
or nursed to sleep.
I mean,
I get that whole well, that's a
very
whole other
different.
thing with sleep and with nursing and everything
sure.
else. So tell us about how people are going to find you if they need to find you.
I'm on Instagram at Diary of a Doula. And then my website is Mama Warrior Doula.
Mama Warrior. Thomas is going to put this all up for us.
Mama Warrior Doula. And then, yeah, I mean, those are the best. Instagram's really the best place to find me, where I actually interact with humans. So, like, if you send me a message or you have questions, also because of what I do, like my niches, I know a lot of people sort of all over the country too. So, like, if you're listening from somewhere else and you want help finding someone that sort of does what I do, I can probably point you in the right direction too.
We're lucky to have you in Connecticut, though. Don't go anywhere.
Yeah. I mean,
don't go anywhere.
This work is hard.
It is hard. It takes a lot out of you.
It does, I think.
We talked a little bit about that. We're going to have a longer discussion about provider burnout for sure.
Yeah, I think it's a thing. So
it is. We'll talk about that. But I'm glad you're doing your thing now. Thank you for coming.
Of course, thanks for having me.
I'm so glad that you're here, and we talked about more challenging ways for birthing parents to find what they need. Thank you.
You're welcome.
Thanks.